Thank you, Dr. Umar, for your kind invitation. Without delaying further, because it's a Friday as well, and we have to break for the prayers. So we would like now move on to the next very, very important session, and that's the diabetic foot syndrome. So I was just reading about it. So the IDF, the International Diabetes Federation, says every 30 seconds, a limb is lost somewhere in the world due to diabetes. So all the more reasons we all should be knowing it and to prevent such limbs. So to start the session, I would like to invite the esteemed chairs for this session. And we have a very experienced group of people, starting with Professor Musaddiq Khan, one of the pioneers of vascular surgery we just saw. So Professor Musaddiq Khan, if you could please come over the left side of the stage. Then we have Dr. Noor Jatoi. He is the professor of internal medicine with special interest in vascular medicine. He's joining us remotely. We have sent him the Zoom link. I hope he's online with us. Then we have Dr. Atif Rana. He's an interventional radiologist at Shifa International Hospital. Dr. Atif, please. And then we have Dr. Mohammad Hanif. He's a professor of surgery and the president of Society of Surgeons Pakistan Rawalpindi chapter. And we have Dr. Noman Imtiaz. He's the vascular surgeon at CMH. So I would like to invite the speakers now. So we are just changing the sequence of the presentation because one of the speakers has to leave early. So I would start with Dr. Zahid Mian. He's an endocrinologist with a special interest in the diabetes foot problems. And he is running a service and a hospital called Baqai Institute of Diabetes with the foot problem. So he would be sharing his experience of running a diabetic foot service in Pakistan, challenges and opportunities. So I would urge all the speakers to be on time. I would be showing you the card at 10 minutes and then we should finish on time, inshallah. Thank you.
Okay, my dear friends, thank you very much. वो कहते हैं कुछ इश्क था और कुछ मजबूरी थी. हाँ, कुछ इश्क था और कुछ मजबूरी थी. तो ये इश्क है जो खींचा लाया यहाँ पर. और ये वो कहते हैं कि गली गली कूचे कूचे क्यों फिरता है. गली गली कूचे कूचे क्यों फिरता है. तो ये जो मजबूरी है, इश्क तो फुट के साथ है और मजबूरी ये थी कि ऐसे लोगों ने बुलाया तो आना ही था. So thank you very much indeed, Professor Iqbal Sahab, Zia and your team as well, to invite me on this prestigious occasion. And of course, it looks that I am the only thorn in this galaxy of stars of vascular surgeon over here. And my dear friends, ये जो last 20 सेकंड मैंने इधर इधर की बातों में लगाया आप लोगों को, is for in last 20 seconds, a lower limb is lost. This is the new data. Somewhere around the world. And this, the number which we extrapolated from the data which we have published, about 300,000 people having an amputations due to diabetes. And वो कहते हैं ना, बात अगर यहाँ तक रुक जाए तो शायद समझ में आ जाए. So if the things are stopped over here, then I say, okay, you have an amputation, but your father is with you. You have an amputation, but your sister is with you. You have a amputation, but your brother is with you, with your family. But my dear friends, the mortality after having a lower limb amputations is worse than some malignancy. And you can name any malignancy except the two malignancy, the pancreatic cancer and the lung cancer. These are the two malignancy. Apart from any malignancy, you are having higher rate of 5-year mortality and people who are having a lower limb amputation. That is what the obsession is. That is why the obsession is, my dear friends. And there are about 3 million people having diabetic foot ulcer. Again, this is the data extrapolated from our publication. And the thing starts from a small ulcer, you already know. A small scratch. Salim Sai पहन ली थी, पेशावरी पहन ली थी, जूता टाइट था. Start from a small problem and leading to an amputation and a high mortality. And my dear friends, it is a costly affair. Diabetic foot is a costly affair. आसान बात नहीं है इसको ट्रीट करना, इसको मैनेज करना. If you look at the problems at the patient level, then you can understand what the patient is having problems. So this was the paper which we have published, the cost 2008. And then if you compare the cost in 2005 and 2021 or 22, then a huge difference in the cost due to the manufacturer, of course. And this is one of the study which we are in the part of the international study of regarding the cost of diabetic foot ulcer. This is one of the simplest, uncomplicated diabetic foot ulcer, which is a Sinbad classification of 2/6, which is a superficial ulcer actually. And the cost is 64,000. This is a direct cost, not an indirect cost. And when you go on to you move on to the, so अगर आप इसके maximum पे चले जाएं, जहां patient को, when the patient needs a vascular surgeon as well as you people over here, or an amputation, then the cost and the Sinbad classification, which is a severely complicated diabetic foot ulcer, which means the patient needs a vascular surgeon or an amputation or a severe infection, needs an hospitalization, which means the cost, my dear friends, the cost is jumped up to over 800,000. कहां से करेगा मरीज? हमारा मरीज, पाकिस्तान का मरीज इसको कॉस्ट को बेयर. Where? Even the NHS cannot afford it. This cost. So this is the cost, my dear friends. So I'm taking you back to 1996, where we have started our journey. There is no foot clinic at all in Pakistan. No podiatry. No podiatric training as well. मैं आपको 1996 में लेके जा रहा हूं पीछे. And we have developed, this is we started as a medical unit 4 in the Baqai. And we started with this one couch, one room diabetic foot clinic. That is how we started. And then we think that yes, we need to have or to educate the general physician, the family physician about the diabetes. And mind you, the number of people with the diabetes, we have this survey, very recognized survey, which is recognized by the HEC as well, and which is recognized by the government as well. 33 million people have diabetes in Pakistan. 33 million diabetes. So this was, again, oh bhai, नहीं चलता भाई. मेरा टाइम इसमें से नहीं काटना. ओके. सो ये एक क्लिनिक्स हमने शुरू किया था. उसके बाद हमने, when we trained the family physician about diabetes, so we started the diploma in diabetes in first time in Pakistan. And now, up till now, over 500 people now. Up to 500 family physicians has been trained in this diploma in diabetes. Only for the diabetes, and they are practicing at their primary care level and the secondary care level as well. And then we started, and we all know that. You must be knowing this fact. World is only 19 countries around the world having the podiatric services. And the UK is on the top, and the US is on the top, where the podiatric services are there. But if you look at the European country as well, there are a lack of podiatric services. So what we have done, this was the idea which is coined by the Professor Abdul Basit in the IDF meeting, that we need to train our own podiatrists. And then we have this Diploma in Diabetic Food Education program, which is a 6 to 8 weeks certificate course to train our people regarding how to dress, how to debride a simple wound. So this is what, and up to now, we have 174 this diabetic foot care assistant. And then we have a certified diabetic foot training course for the primary care physician and the secondary care physician as well. So, my dear friends, you must all be knowing that these are the standard of care of managing diabetic foot. And these are the IWGDF guideline, International Working Group. And we are the part of this, and we are the part of this guideline as well. So, and every 4 years, these guidelines are published. And we have this 23 new guidelines. And according to these guidelines, you need to have a local wound care, pressure offloading and ulcer production, treatment of infection, and the restoration of tissue perfusion, which is more interest by you people, and the metabolic control and the treatment of comorbid. I will not go into the detail of this, but for any ulcer, you need to classify. You must be knowing this. So you need to classify that ulcer for the purpose of having a pathway, how to manage, how to treat. And it also determines what will happen, that it can predict the outcome as well. So we have done this many years ago, that the role of wound classification, and then the sin bath classification. I know the vascular surgeons are using the Wi-Fi classification, which is more common in the vascular people. But for the day-to-day communication in the primary care and the secondary care, the sin bath classification from the UK origin, William Jeffcott, I have worked with him. So William Jeffcott has done this tremendous work for the use of this sin bath classification, which is very simple. And I'm not going into the detail, but this, the traffic light sign, the green non-complicated diabetic foot ulcer, which means 2 by 2, a classification of 0 to 2. But what we have changed into this, because in Pakistan, we know that the infection, diabetic foot infection, is the problem. In the developing country is the one of the problem. So we take the mild infection in this classification, and then the complicated diabetic foot ulcer with a moderate infection or a score of 4 to 5, and a severely complicated diabetic foot complication. So 5 minutes reh gaye. So 5 minutes mein. So what we have done? So we have developed this offloading technique. Locally made offloading technique, ये स्कॉच कास्ट है, ये बॉलर ऑनलाइन टेक्निक है, और ये plaster of Paris cast है. And we have shown the world that this local technique has actually worked. Not everyone can afford a 550 pounds footwear. So this actually only cost of $7. So we have changed the things alone. We have presented this data to the international world. And now we have got this fancy air cast boot as well. And then what we have done, the footwear. And this footwear for this project, 3 years project with the WDF, in collaboration with the WDF. And we have taken 15 street cobbler. And then we trained them into making a footwear according to the standards. And this is the person who came from the Denmark, and the training cobblers and foot care assistant from each center. And the manufacturer is standardized, low-cost, durable footwear, which has to be acceptable as well. Otherwise, मरीज पहनेगा ही नहीं. So it has to be acceptable. खूबसूरत बनाना जरूरी है. नहीं तो मरीज कहता है कैसा भद्दा जूता बना दिया, ये मैं कैसे पहन के जाऊंगा. So it has to be acceptable. And we have presented this assistive technology, great consultation in the WHO, Geneva में ये present किया. And this is the results. Only 3.7% develop first or the recurrent ulcer. And this is the only data which shows the prevention from the first ulcer by using the footwear. So recurrent ulcer say we have got the data. And the other thing which is important is the infection. My dear friends, infection की वजह से पाकिस्तान में and the developing world में जो है वो amputations है. And we have this data about 70%, more than 77% people having foot infection, 40% have diabetic foot osteomyelitis. And the cause of amputation in people with diabetes is infection. The end result is infection. And we have shown this data. And the reason, one of the reasons we have shown this is the multi-MDR. So ये जो multi-drug resistance organism है, these are the problem in Pakistan. We have shown this data कि multi-drug resistance और उसकी अभी वजह नहीं discuss कर सकते. But diabetic foot osteomyelitis is one of the cause. And this is for your interest, the restoration of foot pressure. We have 4 साल में, we have 2,000 people with PAD 4 साल में. Or in 4 साल में, I'm just showing this has been accepted for publication. This is the Wi-Fi classification, and there is no time for going into the detail, but just to show you that this about 60% heal with minor amputation. So we have saved the major amputation in these people by doing an endovascular intervention by UPP, people like you, the Farid over here, and the Zia is here, the Fahad, and the other people who are working in Karachi as well, and the Professor Zahid Sufi, who's a big name for this. And look at the impact of this multidisciplinary teamwork. We have cut down the amputation rate in our center. We started from the 27%, and now, alhamdulillah, we have only 3.9% amputation rate in our center. This is what? But this is my latest paper, my dear friends, foot practice in Pakistan with type 2 diabetes. Where do we stand, my dear friends? मुझे 1-2 मिनट जरा सा दीजिएगा. The conclusion, the knowledge and the practice of foot care were found to be unsatisfactory in most of the patients. This is what 20 साल काम करने के बाद भी ये हाल है. Still we are here, my dear friends. So there are many gaps in not only the skill and the knowledge and the practice of the physician, but also, my dear friends, there is one of the important factor is the delay in referral, which led to a high amputation rate in the people with diabetes. और मैं ये आपको दिखा रहा हूँ. This was the first paper, diabetic foot consequences of delayed treatment. That was 1991 में ये publish हुआ था. And this paper is published in 2018. So 24 साल गुजरने के बाद we are still talking about the delay in referral in people with diabetic foot. So thank you very much. I'm just finishing. So what we have done, we have launched this fast track pathway in the Pakistan. मुझे 1 मिनट दे दें बस मुझे. So this pathway is the fast track pathway is an easy to use tool to reduce delay, referral and amputation in Pakistan. And this is the algorithm over here. And this is the effectiveness. By using this pathway, you can decrease. This pathway has been used in the European country, the UK as well, and has been shown that the high healing rate, decrease amputation, major amputation, and decrease hospitalization. So what we have done, we have aimed to reduce the avoidable amputation across the Pakistan and provide the evidence-based standard of foot care services in people with Pakistan within or close to their vicinity. Family physician को train करना है, and we have trained this. So we have trained a team, एक doctor और उसके साथ एक पट्टी वाला जिसको कहते हैं diabetic foot care assistant. That उसको हमने train किया और ये फिर जो है मोबाइल ऐप बनाया और उस मोबाइल ऐप के साथ a referral system, to and fro referral system from primary to secondary, from secondary to tertiary, and from then tertiary to primary and secondary. जो एक primary care physician के जहनों में है कि मेरा patient जो है फरीद के पास जाएगा तो वापस ही नहीं आएगा. तो ये हम जहन से निकाल देना चाहते हैं. It has a to and fro. So any patient who is referred to the tertiary care has to go to their primary care or secondary care. So this is what we have done, and what, alhamdulillah, we have 81 primary care center in this, 24 secondary care center all over Pakistan, and 8 tertiary care center we have developed in all over Pakistan. So we have made connection with the people for the sake of patient, for the sake of patient. And this is the data. It has got a tremendous outcome. And I'm not going into the detail of this, but we have our barrier and limitation as well. So, my dear friends, यहाँ पर मैं कहता हूँ कि अभी तक काम खत्म नहीं हुआ जिया साहब, हाँ? अभी तक काम खत्म नहीं हुआ है. मुझे और आपको अभी बहुत काम करना है. हम सबको बल्कि बहुत काम करना है. And we need to have moving association, corporate, ministry, NGOs, welfare to cut down, to reduce the healing time, to improve the quality of life, to increase the limb salvage, and to decrease the mortality in people with diabetes, my dear friends. और ये जख्म दिनों में नहीं है, महीनों में, हफ्तों में हुए हैं भाई. Delay in referral is the problem. So, my dear friends, time is for action is now. It is never too late to do something to prevent. Thank you very much indeed.
Thank you very much, Dr. Zahid. You can catch up your breath now. We had to rush you through. So we now move on to our next speaker, and he is Dr. Rizwan Haroon. He's the orthopedic surgeon with special interest in foot and ankle, an integral part of the diabetic multidisciplinary team. He is joining us remotely from Karachi. Dr. Rizwan, can you hear us?
Yes, Dr. Fareed, I can hear you, but I cannot kindly tell the host to enable share screen so that I can share my screen. So I will first, my name is Dr. Rizwan. I am a foot and ankle surgeon at Aga Khan University Hospital. So I like the wordings of Dr. Zahid that delay in referral is the problem. And we are lucky at Aga Khan that because of our excellent vascular team by Drs. Ziaur Rahman, Fareed, and Dr. Nadeem, so we usually get referral well in time. So I have no conflict of interest to declare. So whenever we are evaluating a diabetic foot, it is very important to look at the pre-operative wound status and the skin status of the patient. So approximately 1 to 4% of patients with diabetes will develop a new foot ulcer every year. And it has been reported by Dr. Van Battam that patients with diabetes have a 25% risk of developing foot ulceration. And, of initial diagnosis. So, being a foot and ankle surgeon, my aim is to prevent amputation by decreasing the deformity which causes ulcers. So, this is an Armstrong classification of diabetic foot surgery. It is in class 1 elective, class 2 is prophylactic. And this is the point where we want our patient to visit us. And thanks to the vascular team at Aga Khan, we are usually getting our patient at this time. And in class 4, there is basically acute limb and foot salvage, where, for example, as abscess or gangrene. And in class 4, we are usually lost the battle. So there is a very simple thing. Achilles tendon lengthening, as you can see, can decrease the forefoot ulcers in diabetic patients because most of them have got equinus contracture. And mind you, this is a very small daycare procedure done under local anesthesia. And it helps in particularly resistant forefoot ulcers. And it is very easy to perform. Yeah, it has got this complication of excessive lengthening, but if you are experienced in doing this, it is very good. So this is a Foot and Ankle International Journal, which is considered to be very good in our foot and ankle community. And it has got grade A, strong recommendation that tendo-Achilles lengthening is a very important procedure for preventing recurrence of ulcers and healing of ulcers. Another small procedure is the flexor tenotomy. We have seen many of our patients with tip of the toe ulcers, which usually progress to midfoot ulcers and abscess formation. So it is a very simple procedure. You can also do it in the clinic. But the important thing is that the recurrence rate is very high. So in our part, in the study published by Dr. Christian, So we have got grade B recommendation, which means that it is acceptable but not very, very efficient procedure because the recurrence rate is high. So here you can see the animation is showing you how to deal with this. This ulcer will never heal if you are not doing an offloading thing. Yeah, we all start with conservative management. That is the cornerstone of any diabetic foot problems. But once it is established that the point is there, point of contact is there, so you have to release the flexor tendon, and it can be done in clinic with minimal complication. But yet the recurrence rate is high. So I've already discussed this. So now after 2010, there is an increase in demand of minimally invasive surgeries for diabetic foot. So we call it as DMDO, minimally invasive distal metatarsal diaphyseal. The name is very fancy, but the following slides will make you understand what I'm talking about. So in this slide, you can see that in A, there is a ulcer over the neck of the fifth metatarsal. So B is immediate post-operative. We do a distal metatarsal osteotomy. C is 6 months and D is 2 years. This is how the ulcer heals. It is a very simple osteotomy done under local anesthesia, and it is basically percutaneous. You don't have to give big incisions, hence the chances of wound infection are very less. So this works. This is basically an offloading osteotomies, DMDOs. This is another case. In A, you can see there is a big ulcer on the base of the second metatarsal. You can always start with offloading. But mind you, whenever there is deformity, until and unless you make sure that the deformity is not the point of stress causing ulcers, it will never heal. So in this case, as you can see, that there was an hallux valgus together with a second metatarsal plantar ulcer and clotodeformity. So we did second, third, fourth, fifth metatarsal DMDO and correction of hallux valgus with flexor tenotomies. And on the extreme right of your screen, you can see that the patient ulcers and things have healed in about 3 years' time. So what is the concept of this offloading osteotomy? Here is a diagram which will make you understand. So this is the metatarsal head and the base. You cut it off, and when the patient put weight on the ground, this will elevate. Rather than becoming a point contact of stress, it will be offloaded. You can see here in the diagram, the arrow pointed out that when the same patient puts weight, so it is elevated, which we want and which is required. So this is a very important concept in our foot and ankle community, that beaming of the Charcot foot. So here is an X-ray of a very, very deformed foot. So these are the X-rays, and as you can expect that this is the picture of the patient. You can see that this is a time bomb waiting to explode. This has already exploded because the bone is here and the patient has been walking. After all the conservative management, if it fails, so we have to go for this beaming. So every procedure starts with a percutaneous tendo-Achilles lengthening. Then we make the hind foot aligned so that we can rotate the entire forefoot over it. So this here you can see that we took out the medial cuneiform because it was extra and we will use it in the bone graft. So we did an osteotomy and we did correction of the abduction. So here is a very good slide. In slide A, corner A, you can see that the foot is rotated, and if it is fixed in this A point, the patient will continuously have ulcers over the lateral border of the foot. The patient will be walking over the lateral border. So we derotated, and we have to do this in like shown in figure B. So this is the example of what I was telling. These are big screws. This is the screw 7.0 mm screw from the stabilizing the medial column, and this is the lateral column. And we usually do a subtalar arthrodesis to have a very good construct. So here is an X-ray of the same thing. Here is another example of one of my patients, which we did a beaming. So here, the big arrow is showing that whenever you are walking, the most stresses are over this area. And these screws act as weight sharing devices, and they support the bone from collapsing. So with this, I would like to conclude that the surgeon must consider and discuss the risk and benefits of treatment to the patient, particularly the diabetic foot. There is always chances of infection. So the patient should understand and understand of soft tissue and bone infection. The rate of amputation is also very high. And it was published in one of the study that more than 50% of foot ulcers are treated for infection and 20% of them will develop osteomyelitis. And about 6 to 15% of foot ulcers usually end up in amputation. So adequate assessment and multiple disciplinary team approach is required for managing these kind of patients. Thank you very much.
Thank you, Dr. Rizwan. We will now move on to the last speaker of the session, Dr. Atif Rana, who is discussing very important and very challenging tibial angioplasty case presentations.
Assalamu alaikum. Thank you. Probably good to be last speaker. Wonderful talks by the first two speakers on this topic. Enjoyed both of them, learned a few things myself. So I'm going to talk about where we come in, improving the vascular flow to the foot. Excuse me. Okay, it's moved. So I'll be basically have some case presentations overlap. We'll talk about the techniques and principles, and also briefly talk about outcomes. There's some controversy as well on this topic. And I'll show what the current data shows, not in too much detail because of constraints of time. So we'll start off with a first case. This is a 69-year-old male who's a diabetic. And as you heard Dr. Zahid mention, it starts with a small trivial injury to the toe. So he has a right foot injury to the nail and evolves into a foot abscess, 4-foot abscess. And he's been treated somewhere else. His INDs done, back dressings done, antibiotics given, and he comes to us in Shifa. This is his CT angiogram, and you can see on the CT images, there's no inflow disease on the in the iliacs or the SFAs, but he has significant disease. There's a lot of calcium in the below knee vessels. CT is not particularly good for evaluating the degree of stenosis in these patients. MR has some advantages, although that's a different debate. So most of our patients, for the ease of it, I think, end up getting a CT angiogram as the imaging modality of choice. So we proceed with an angiogram in this guy. This is the level at the knee, and below knee you can see the posterior tibial has a long occlusion. It also has disease in the peroneal artery. And in the foot, you can see some vessels. There's a dorsalis pedis going in the plantar. Vessels are also going. So we treated his peroneal and posterior tibial arteries, and resulting with good flow. So a few slides about the technical considerations, how to approach these patients for below knee angioplasties. So most commonly we do antegrade common femoral puncture, which can be a challenge in a very heavy patient, but it's manageable, especially if you're using ultrasound guidance. Going antegrade gives you a better pushability for the catheter and also torqueability or guidability of the wire going this way as opposed to going up and over. So from the contralateral femoral approach, it becomes a little difficult, but you can opt for that if they have an iliac component as well. And if you don't expect to go up to the ankle, but you have to make sure your inventory is adequate. You have enough length catheters and balloons to be able to go up and over and treat these legs. Popliteal approach is also described. You can use a prone position. I've probably just done it once, maybe, very rarely used. So the standard tools are for a sheath in the groin, which is mostly a 5 French. Some people will use a 6 French as well. Length is dependent on what your choice is, 11 or 23 centimeter, or even longer, up to the knee with 40 centimeter long sheaths. For below the knee work, most operators will prefer a 0.01 0.014 guide wire, such as a pilot or a V14. You can also use a 018 wire or 035 wire in some limited instances. And also, obviously, there are some heavy tip weighted CTO wires. Most of these have come across to peripheral work from cardiology, but they are difficult to use at times, and you have to be careful with the heavy tip weighted wires. Over-the-wire balloons are preferred instead of the rapid exchange balloons or the monorail balloons, which are both the same thing. So the over-the-wire balloon gives us a better pushability, and wire exchanges are easier. And you can also, once you put the catheter inside, distally, you can do a little contrast injection as well through the luminous. Support catheters is something. So for angioplasty, the two options are transluminal or subintimal approach. So it depends on what the vessel looks like. It's calcified or non-calcified. For calcified, heavily calcified vessels, our approach is we try to go intraluminal. Subintimal may not work. It may collapse the lumen. But if it's a non-calcified, obviously we prefer to go intraluminal, but subintimal becomes a possibility as well in these vessels. So the transluminal or intraluminal angioplasty recanalization is preferred for stenosis, short occlusions, and bifurcation lesions. In heavily calcified long CTOs also, we prefer to go transluminal. You can use this, you'll need a support catheter, and I think it was discussed in the morning session as well. The cost is a prohibitive factor. So you have dedicated crossing catheters from different companies, as I've listed here. I tend not to use them. We'll just use a 4 or 5 French catheter, diagnostic catheter, and try to get across these occlusions with help. But these are helpful if you're really stuck, because they are very stiff catheters to cross an occlusion, a long occlusion. So for wire maneuvering, there are a couple of motions that you can do for CTO, which is essentially a drilling motion where you put a wire tip in at the level of the occlusion and you go 180 to 360 degree rotating movement, or a penetrating motion, which is more like a jackhammer and you're trying to hit the plaque with your wire. Subintimal angioplasty and recanalization. When you're not able to pass through the lumen, you can make a loop, for example. And the preferred wire for subintimal in the below knee area is an 014 wire. But again, cost. They trash very easily. And once we open a wire and you have to open another wire, it becomes a problem for us, especially someone like me who's in a private setup. I'm sure it's in the government setup as well. Cost is always an issue everywhere. So at times, we can end up with using an 035 wire below knee to make a loop. But you have to be just careful not to make a very large loop, because then it becomes a problem. You can rupture the vessel easily. Retrograde approach is another approach, a variety of techniques, and it's used as a last measure because you can easily lose that vessel that you're trying to puncture distally and trying to come back up. So the 3 ways that are described are transcollateral navigation and retrograde canalization, the very known pedal plantar loop technique, or a retrograde distal axis and recanalization, such as puncturing ADP. And I'll show you a case for that. So angiosome concept coming to this, make a big bang a few years ago, and most of the therapy was directed with angiosomes. There's some controversy now, but the angiosome-directed angioplasty is still preferred, I think. It improves your rate of ulcer healing and leg salvage. But data has shown that non-directed revascularization should still be attempted if directed angioplasty in the particular angiosome is not possible. This is just an example of one of the papers, not my case, but ischemic first toe ulcer. And this was treated with an anterior tibial angioplasty. And you can see that the whole artery is now nicely filling in the last image. So one of our cases, 77-year-old male who's a diabetic, presents to our vascular surgeon. He's had first to third toe amputated. And it got some slough on the fourth toe as well. So this is his angiogram, and you can see there's disease in his AT. The PT is occluded. There's some disease in the peroneal as well. And looking at the foot, there's not a whole lot of flow. There's DP going in there, but there's no plantar arch. So this patient ended up with the angioplasty of the anterior tibial and peroneal artery. And it did improve his, if you compare the two, maybe not well projected, but it did improve his flow, but not really well. So he had some slow healing going on. He had a transmetatarsal amputation. So you have to keep in mind these patients have small vessel disease as well, and that sometimes may not help the patient despite these revascularization procedures. Another debate, how many vessels to treat? I try to be conservative, but the main thought is if you open up something once, you want to go to the other vessel, you don't want to risk the trashing the first vessel in the process. So there's literature on this, there's papers on this as well, single versus multiple vessels. And I think the important concepts to consider in this area are the angiosome concept and the pedal arch patency and trying to establish direct inline flow with this pedal arch. So this paper showed outcomes of one straight line flow with and without pedal arch in patients with critical limb ischemia. And they showed that in patients with CLI with only one vessel runoff can be established in the foot. Direct flow into the patent pedal arch is essential to improve the clinical outcomes. However, this paper in 2020 in Journal of Vascular Surgery showed that multivessel tibial vascularization does not improve outcomes. And there was no difference seen at 1 year between the single versus multivessel treatment. So current status is it theoretically ideal to revascularize the inflow artery to the foot angiosome affected with a wound, but achieving inline flow with either the anterior tibial or posterior tibial artery benefits the patient regardless of ulcer location. Just another case, 80-year-old. That's a challenging in itself, given her age. Diabetic, left big toe gangrene. And you can see she's got a AT disease, focal stenosis, in the distal AT, mid to distal AT, and also the foot doesn't look very nice either. So we fixed the AT, and once we have a better flow because of that stenosis been fixed, look at the foot again, and we noticed something. And if you do an AP view, you can see it's got a very tight stenosis in the DP as well. And that's why for the foot vessels, you should always consider taking the, I'd prefer to do a lateral working view, use a lateral working view, but you should always consider doing an AP view as well, just for identifying these kind of problems. Another case, 72-year-old male, diabetic, left third toe wound. And again, he's got very poor flow in his foot. He's got occlusion of his PT. He's got a peroneal disease as well. And once we do an angiogram of the foot with some distal catheter replacement, you can see there's just collaterals. There's no good single inline flow in the foot. So you can debate what to do. We decided to try to cross it gently, and we crossed this and did an angioplasty. And he's got a good DP at the end of the procedure. So this is a right big toe gangrene. You can see this patient has no inline flow. There's no runoff present, and there's collateralization, and there's a DP present there. So this is one of my colleagues' case, but he asked me from a few years ago, actually, but he asked me for opinion and help, so I scrubbed in, and we ended up puncturing this DP retrogradely and finished the case, and end result was he got a good antegrade flow in his anterior tibial, in the dorsalis pedis artery. This is a continuation from the peroneal artery going all the way. Renal insufficiency is, these patients all are high risk for renal insufficiency. They have problems with their kidneys, obviously being diabetics. IV hydration obviously is very important for all of these patients. And in the past, where things have been used without clear benefit. So all we're left with essentially is IV hydration. But in these cases, don't forget to use CO2 angiography. We use it occasionally in these patients, and it's the system that we use is not a dedicated CO2 angiography machine. The Droid system, I think that's what it's called. It's very expensive. So we use more of a homemade kit, fill up the syringes with the CO2 from the CO2 cylinder, and you can see this is entirely a CO2 angiogram. And the image quality becomes a little grainy. You have to do a few maneuvers, raise the legs up a little bit to let the CO2 flow. But you can kind of see all the way up to the ankle and decide, it helps you decide what to do. And this is now switching to just dilute contrast to get better delineation while we're intervening. And you can see there's a little short occlusion there, which we have fixed. And now he's got good flow in the arteries there. And a total of 16 cc's of contrast was just used throughout the procedure. Just briefly, very briefly, I'm out of time, I think. Best CLI trial, that's the controversy right now. It shows that a patient had an adequate greater saphenous vein for revascularization. That's the go-to the method right now. The incidence of major adverse limb events or death was significantly lower in the surgical group. And among patients who lacked a vein conduit, the outcomes were similar in the two groups. There's some criticism. One of that is that the exclusion criteria is these patients were not very high risk. They excluded the cardiac patients, high-risk cardiac patients from the open vascular surgery cohort. And the problem is that I think most of these patients do have underlying coronary artery disease. The next trial is the Vessel 2 trial, again showing this was a vein bypass first versus the best endovascular treatment first strategy. And what it showed was that the best endovascular treatment first revascularization strategy was associated with a better amputation-free survival, which was largely driven by fewer deaths in the best endovascular treatment group. Again, controversy, comments, you go on the net, there's a lot of literature as well arguing about it. This is one of them. This is a follow-up study. Bypass versus angioplasty, published just recently in 23. It's a single center study. And of their entire cohort, only 18% of patients who presented to them, they were able to randomize into Vessel 2. So these patients accounted for a very small subset of CTLI patient population as a whole. So summarizing, just treatment of CLI patients should be individualized based on, I think in our setup, very important, what's the expertise available. You have a surgical expertise, endovascular expertise. So I think Best CLI has opened the door for below knee bypass again. It's come back into fashion again. But you have to consider individual patient needs. You have to consider the specific anatomy, physiology of the lower limb arterial system, and patient preferences, and importantly, very importantly, comorbidities, how sick they are, how unwell they are. Thank you.
Thank you, Dr. Rana. For the sake of time, because we have Jummah prayers on 4th floor at 1:30 sharp, so we would omit the questions. We can take those on the lunch. I would request Professor Musaddiq to please give us concluding remarks, and then we can break for the lunch. Followed by that, we will do the inauguration of the exhibition. Okay, I don't mind. Okay, we can take two questions, Dr. Ilyas and Dr. Okay, yeah, after Dr. Ilyas, I'll come to you.
Thank you very much, Dr. Atif. Very, very nice presentation, very elaborating. I do a lot of tibial work for the last 10 years. And you were talking about subintimal angioplasty in the tibials. So, are you really serious, or what's your experience about that? I've never tried that anyway.
So, as I said, the first preference is intraluminal. In a long CTO, you can go with the subintimal approach, and I prefer to use 035 wire. I worked with someone who worked with Aman Bolia, a UK guy, and I think he prefers 035 system below knee. And I saw some really good results. And I've had a few cases where I've used 035 system. I don't prefer 014 because of cost. I know it will halfway down the length, it will really lose its shape. So I don't try using 014, 018 systems, but it does work. It does work.
Considering the size of the vessel,
just make the loop very short, very short. The longer loop it is, the loop becomes very big, like 3 times the size of the vessel, and then it's not going to work. You're going to traumatize the artery.
And second question is about, do you have any contraindication to go for TVLs? Any specific anatomical issue where you don't want to go in?
Well, if you don't have anything in the foot reconstituting, then obviously it doesn't make sense to go for revascularization in that case.
Okay, thank you. I'll go to last question. Yes, Khalil. Dr. Khalil from Karachi. Khalil, can you please collect the microphone? Yeah, thank you.
Thank you, Dr. Farid. I am Dr. Khalil from Trauma Center, Karachi. We used to do infrapopliteal tibial angioplasties. We have dedicated 2 cath labs and we have dedicated 2 cath labs and do around 10 to 20 cases in a week. My question from Dr. Rana is that in the condition when you have difficulty in traversing wire in very heavy calcified vessel, then how you approach in this condition?
So for a heavily calcified wire vessel, again, this is probably outside the book or outside beyond the literature. Sometimes what I do, obviously you have the support catheters. That's the first thing that you should use beyond the regular catheters because they'll help you. They're a few thousand rupees each. One thing you can do is in these vessels, as I said, 035 wire does wonders. People are scared to go below knee with an 035 wire. If you're very gentle, and you're using that drilling motion or jackhammer motion with a wire, don't make a loop first, and you keep going and advancing the catheter. I think the failure rate to crossing the CTO with an 035 is very low. And then you can switch to your 014 system once you've crossed with an 035 wire. No, we don't have atherectomies with us, device.
Okay, thank you. Dr. Musaddiq, please.
Thank you very much. It was indeed very illuminating presentations, and I think that I'm sitting where I am sitting now at the end of my almost at the end of my professional career. If I had to look at a few things which really bother me, one of them is diabetic foot, and I think we as a society, from the platform of the society or in what way possible, we have to develop, I was listening to this young man from Baqai. We have to develop some programs like that to take care of diabetic foot. And I think this should be, this is a good platform where at least we can start talking and start doing something about preventing amputations and morbidity associated with diabetic foot. Thank you very much.
Thank you, worthy chairs and Dr. Noor Jatoi, who was joining us online. I thank all of you, and we expect the same audience after the lunch as well. So the last announcement is that for the lunch, you need to produce this red coupon in your badge. Only then you are going to take the lunch. Thank you very much.
I really thank Dr. Zahid Mian for coming all the way from Karachi and delivering a wonderful talk. Thank you, Dr. Zahid Mian. Thank you.